And everyone is free to speak throughout the meeting. Since there are a lot of people in the meeting, we like to sequence the speakers when possible. So please signal to the team if you'd like to speak. One method is using a sheet of paper, which you can fold up like this. It's best to try to hold it up so we can see it, so if you can see yourself on the screen. The other way is there's a little hand button at the bottom, which allows you to raise your hand. So that's all I have this morning. David, I'll turn it back to you.
So thank you, Melanie. And for those who are just joining by the telephone, Melanie, any recommendation there? So
there is a way to unmute on your phone. If you would like to speak, you can just try to unmute. There really isn't a way for them to message, so they'll just have to unmute and then ask if they can speak. They could email an NRI and we could check it, but I don't know if that's too difficult for people.
Yeah, why don't we then go with the process for those who are on the phone to just do a slight sort of interjection, and we're happy to answer questions or communicate with the group via that mode, if that works for everyone. So let me introduce you to, let my team introduce themselves to you. We have a number of folks from the Maryland Healthcare Commission. So again, my name is David Sharp. I'm the director for the Center for Health Information Technology and Innovative Care Delivery. I am one of 4 centers in the organization. Our executive director, Mr. Ben Steffen, he may be joining us a little late today. He sends his regards in the event that he is unfortunately been called away and may not be able to join us today. So let's go around the virtual room if we can, and just have my team introduce themselves to the group and let you know who they are. So, and why don't we start with Anani and then work through everyone else.
Hi, everybody. Good morning. Apologies, I am off the screen. I will be joining later at the end of this meeting because I'm projecting. But my name is Anene Oyabo. I am a program manager in the Center for Health Information Technology and Innovative Care Delivery. And I work specifically with innovative care delivery initiatives.
Wonderful. Thank you. Who else from my team?
Good morning. This is Christine Karanopoulos. I support David Sharp and the entire team. We welcome all of you. Thank you.
Yeah, I'm Nikki Majewski. I work with David Sharp and Melanie, and Anene and Christine as well.
And I think we have Alana.
Good morning. Yes. Hi, good morning. Alana Sutherland. I'm the Chief of Health Information Exchange. I work with the team as well, listening in this morning. Thank you.
Wonderful. So can we get the CRISP team to do some basic introductions?
You certainly can. Good morning, everybody. This is Craig Bem. I'm the Executive Director for CRISP.
Hey, good morning, everyone. Brandon Nicelender, Chief Operating Officer at CRISP.
I'm Mike Fier. I'm an advisor to CRISP.
Morning.
Morning, David.
Okay, and why don't we go through the folks that we have from the electronic health networks, and we can leave this to random order, or I can try calling on folks, which probably is going to be more process driven. So let me just call your name, and then if I've missed anyone, please feel free to jump in at the end. I believe I identified on the call Karen Cristolini. Can you say hello and a little bit about yourself?
Hi, yeah, it's Karen Cristolini. I'm the Privacy Officer and Compliance and HR at P&T Data. This is, we are MHCC certified, but this is our first time to really be involved in one of these work groups. I'm looking forward to it.
Wonderful. Good morning. Mike Dennison.
Good morning, everyone. Mike Dennison with Change Healthcare. I'm responsible for Change Healthcare's administrative, regulatory, and standards compliance.
Good morning, Mike. Thank you for joining us. Wes Hassel. And Wes, I don't know if you're on mute or we just lost you.
Sorry, can you hear me now, David?
Indeed. Good morning.
Oh, hi, good morning. I thought I'd unmuted. Wes Hassel with Allscripts. I'm a Senior Solutions Manager for Regulatory Compliance. My first visit to this group, so Glad to be here.
Wonderful. Thank you. Good morning. Jeff Logan.
Hey, good morning, everyone. Name's Jeff Logan from Availity, Senior IT Auditor, and I typically assist with these accreditations that we do. And yeah, glad to be here. Thank you.
Wonderful. Good morning. And why don't we go with Kathy Seitz, who's a colleague, I believe, of yours. Kathy, maybe you're on mute from what I can see.
Hi, I'm Kathy Seitz with Availity, working with transaction mandates and standards.
Wonderful. Good morning.
Good morning.
Kathy Romanek.
Good morning. I'm Senior Director of Product Management at Cover My Meds, which was formerly known as Relay Health and is a division of McKesson.
Wonderful. Thank you. And I think Carol Rosenthal, did I get the last name correct? And you may also be on mute. Okay, we'll come back. Hopefully Carol can join us, return to the work group. Anyone else that I missed?
Yeah, you may have been talking about Tara Rose and not Carol Rosenthal.
My apologies. Yes, ma'am.
No worries. No worries. I am Tara Rose with Optum. I am a senior BA on our product that handles standards and mandates.
Got it. Thank you for joining us. Sorry about messing up your name.
That is okay. No problem.
So again, happy Monday to everyone. Thank you all for joining us. Let me just say a little bit about the landscape in Maryland. During the last session, the legislature passed a law which you all received a little bit of information about from Ms. Cavalier, I believe, on Friday. And this law is codified in chapter 790 and 791 of the laws of Maryland. And it's really as a result of a House bill that was sponsored by the chair of our Health, Government, and Operations Committee last year. And this bill is called Public Health State Designated Exchange Clinical Information. And it's House Bill 1022 for some of you who might be interested in taking a look at it. The law does several things, but one of the things it specifically does is it requires electronic health networks to provide transactions to the State Designated Health Information Exchange. And in Maryland, CRISP, the Chesapeake Regional Information System for our patients, is that State Designated Health Information Exchange. And the purpose of these transactions, if you will, are for improvements of public health, therefore mitigation of public health emergencies, and also improvement in patient safety. This bill, conceived of by the legislature, was passed by the General Assembly, and it became law on July 1st of this year. So in Maryland, there are roughly, and Amy, keep me honest, I believe it's 30 now, approximately 30 electronic health networks.
That's correct.
Is that correct, Amy?
Yes, that is right.
Thank you. That are certified by the Maryland Healthcare Commission. And in Maryland, in order for a third-party payer to accept transactions from an electronic health network, that electronic health network must be MHCC certified. Otherwise, the payer is not permitted by law to do business in Maryland for transactions originating in Maryland with that network. So roughly 30 networks are certified, but the lion's share of transactions, the volume, if you will, is really by 6 networks. And most of them are represented on this call today. A couple of the networks have the larger chunk, if you will, of that volume share. So what we are doing today, and probably through a couple other meetings for the end of the year, is trying to we wanted to convene a group of thought leaders such as yourself and talk about a process in which we could begin to implement the law together and work slowly in a methodical approach that doesn't rush the process unnecessarily, and that we can do it in sort of graduated steps and come up with some learning lessons along the journey, as well as create what you might think of as an implementation approach or guidance material that can help others that perhaps go after you all through the process. And today we wanted to start by talking about a transition strategy, which says one way to do this would be to talk to the group and see if there's any interest or willingness among a few perhaps, of the networks on the call to engage Chris and work with Chris to look at how we might be able to move forward in testing the receipt for Chris to receive the 837 P claim transaction as a place to start. And this starting ground, which Craig will talk to you about in a few moments, would be a way to just sort of ferret out any of the challenges and implementation hurdles that could guide a smooth transition for others once the process has been what you might call developed in terms of a strategy guidance document. Just a little bit more on the background section here. Probably about 4 years ago, and I believe Brandon, you can remind me if my memory's failing or accurate today. Relay Health worked with Chris to test out accepting the X12 837 and to really look at what are the challenges and implementation hurdles and come up with solutions to those challenges. It was a pilot project of sorts, and the general consensus of Relay at the time, as well as the HIE leadership, was that it was fairly successful. And so Brandon can talk a little bit about that in a moment. Why don't we pause there, and Brandon, can you sort of fill in some of the detail of what I was speaking about at a high level?
Sure, David. Like you said, about 4 or 5 years ago, we wanted to understand if there was an opportunity to utilize some of the data that flowed across national, some of the clearinghouses to extend some of the public health use cases that CRISP was managing. Specifically, we wanted to understand if this type of data could help with care teams and provider relationships that we were lacking to get some at that point in time, and still today, connecting through national networks to get some of these relationships, or connecting to multiple EHR systems that might not have as much interoperability capacity. That was difficult. So that was one of the things we wanted to do. We also thought that, there was some pretty interesting clinical data that comes along with some of this information when it comes to claims, specifically diagnosis and medication data, maybe some procedures and conditions. And as we thought about, could we get access to some of this data? If we did it, could we parse it and make that data available and represent it in the CRISP infrastructure at the time? We were able to be very successful. I think that there was a lot of lessons learned. There were some, I would say, some areas where data needs to be enhanced, and we've built some tools since then, specifically around provider directory. The provider data was somewhat less than perfect when it came to communication out to someone who would use this data to make a clinical decision. So those are some great things that we learned, and I think that we're ready to move forward. I don't know, David, is that helpful?
Yeah, thank you very much for that. And before we turn to Craig to talk a little bit, let me pause and see if there are any questions amongst the representatives from the networks here on the call.
David, hey, this is Mike Dennison from Change Healthcare.
Good morning, Mike.
I just wanted to clarify that the legacy Relay Health, part of McKesson Technology Solutions, is now part of Change Healthcare. So that Relay Health exchange that processes the administrative transactions is now part of Change Healthcare.
Wonderful. That's very important to know. Thank you for sharing that.
Yes, thank you. This is Kathy Romanek from Relay. I had my hand raised to share the exact same thing, just to clarify, because not to make things more complicated than my already complicated formerly known as, but I'm from the Relay Health division that's formerly known as NDC Health. And the Relay Health division, that was the clearinghouse, is, as the other speaker just noted, part of Change now.
Yes, that is true. This is an industry where there's often consolidation and there's oftentimes a lot of movement around the networks. Anyone else have any questions or comments at this point? Okay, so let's turn our attention a little bit to how we could talk about perhaps a transition strategy that we'll call it a glide path to implementation that's really more as a go slow and be very thoughtful. So let's invite Craig to talk a little bit about some thoughts he may have as the leader of CRISP, as one of the leaders of CRISP.
Thank you, David. I really appreciate that, and I appreciate all the groups being on the call this morning. First, I think it's really important to describe this as a transition strategy, and I like the idea of a slow and methodical pace. I think we're all thrown in this because there was a lot of opportunity to support public health primarily through the existing HIE infrastructure and the existing data flows that you all have in place. And we don't want to be disruptive. We don't want this to be more of a headache than it may already be perceived to be. And so I think probably much of the time today, actually, we're looking forward to listening to thoughts, feedback, things that both MHCC and CRISP can help provide to have a thoughtful approach that you all can work with. I think we're really open to different strategies. We obviously, as Brandon outlined, have rich experience across the connectivity landscape, across thousands of provider groups and millions of transactions per week. As Brandon said, also, we've updated much of our technology since last time we worked with things like 837s. So we have mostly an Azure native stack. We're not concerned about kind of volume or traditional interoperability issues. And I think really one of the open questions is kind of as we transition, kind of what's the right incremental approach to this? Is this going to be only with a specific transaction type at first, because there's probably some quick wins that we can all get through specific messages? Is this maybe more about providers or geography? Or is there some kind of all the above strategy that you all would recommend? I'd also say that we are intending to be incredibly flexible. And so if there is a group that would potentially volunteer to go first for a transition, I think we would work with them to create an optimal approach, which could then serve as perhaps a playbook for other networks. So David, I'm not sure I have anything much more specific, but I do want to emphasize that we're really trying to be flexible partners in this and don't yet have any preconceived notions on the best way to do it. And we're really eager to learn from the experts.
Yeah, I think that's a good way of summing it up. So let me see if I can just sort of recap. The experience of the pilot were very, very informative to the work that Chris has done and has done since the pilot. It was very successful overall. What we are thinking, and we really would like to explore with you all today, is a go slow approach, is to see if there are a couple of volunteer networks that would help work with Chris to implement the 837P exchange. And we use that, I like Craig's words, as a playbook that can be shared with other networks. Obviously, there may be some uniquenesses for each of the networks that's required for them as well as for Chris. And then to gradually move forward to eventually have all the 837Ps. Now, we would want to work out a timeline and more of a detailed work plan. And what we think we would do is work with whoever might be an organization or two. I don't know if Craig or Brandon have in mind a number yet, but we can talk about that to really look at what are the challenges and opportunities, and then look at a time frame for how this might effectively work through the process, because there will be learning lessons that can be shared with the other networks. I don't think we want to try to throw the switch quickly or all at once. I think as data people, you all know that that's a recipe for disaster and and headaches. And that is two things we're, as the commission, we're working feverishly to avoid. Yes, we want to move forward, but we started out by saying in a gradual, thoughtful approach, and I think that's going to work best for everyone. There's also opportunities for the networks, and I'll come back to Craig in a moment, to access the data that CRISP would receive through the 837s and other transactions over time. There may be specific use cases that you all could conceive of that where data, providing it meets with all the requirements for release, you all might find as valuable as well from Maryland. So that too is something to consider, where we realize that the requirement in law mandates a push to the state, HIE, but we also view that there could be opportunities for the networks to use some of this information as well. So we want to keep that in the back of our mind. So let me pause there for a moment, and before we dive deeper into an implementation discussion, see if there are comments based upon what you all have heard thus far. Okay, hearing none, let's talk a little bit about the implementation opportunity. And with that, the next step would be to see if there's anyone on the call that would be willing to work with Chris on the 837P to work through some of those challenges in pushing data for transactions that originate in Maryland to the state designated HIE. So let me pause. And perhaps you're not ready to commit today, but if there's some on the virtual meeting room here that potentially could explore this opportunity a bit more, we would appreciate that. So I was expecting everyone to jump forward all at once. So you all are disappointing me a little bit. Is there anyone, could we sort of volunteer a couple of electronic health networks to work with the HIE? And I would suggest, probably given the experience that that Relay Health had, Kathy, and then now part of Change with Mike, that there may be a huge benefit to your organization working with CRISP on the 837P to work through some of those challenges. Any reaction here?
This is Kathy. So my business unit works with NCPDP transactions, not X12 transactions. So the work that was done by the Relay Health Clearinghouse business unit that is now part of Change was not, they were not part of my group. Yeah, it's confusing, but McKesson had multiple business units that all started with the name Relay Health.
Yes,
and,
I recall.
Yeah, and so my business unit that I'm representing is the business unit that dealt solely with NCPDP telecom transactions. And there was another business unit change that it now went to Change Healthcare. So as much as I would love to participate in this, I don't have the expertise.
Well, no worries. We imagine that through the process of implementing the different transaction types that while the NCPDP transaction is not probably first or second, it's probably closer to the bottom, right, potentially. It's still on the list. So the learning lessons here will be valuable for much of the work you're doing. So Mike, what is your reaction?
Hi, David. Many on the call here are members of the Cooperative Exchange, and the Cooperative Exchange earlier this year had sent a letter expressing some of the concerns that I believe still prevail today. And some of those are around violations of federal law, policy, types of things, HIPAA, privacy. So I think that we need to really talk about some of those types of, concerns before we jump in and say, let's just start sharing data. We have to make sure that we're sharing data appropriately. We have to understand, how it's going to be used. How do we get to understand which patients have opted in versus opted out? There's just so many questions, and there's so many operational and I'll say, financial sustainability questions that I think the EHNs have.
Yeah, so that's an outstanding point. I was wondering when that was going to come up. So I think before we get to that, I want to pause for a moment. Our executive director, you see, has joined, Mr. Ben Steffen, and I thought he might want to make a few remarks to the group. And then, Mike, we will get to your point, which is a very good one.
Yeah, thanks, David. I was double scheduled this morning, so I'm just getting on the call now. I want to thank everyone for joining us this morning. I think a couple points that I want to emphasize that this legislation was really very broadly supported in the Maryland General Assembly and signed by the governor. We understand there's work to do, but I think we believe that the direction of the legislature on moving forward with the integration of information held by electronic health networks for purposes of public health is a really important objective. I understand there are issues that need to be discussed and consensus built, but I think what I want to emphasize is there was very strong momentum moving forward. As many of you know, the information shared through CRISP is, and I think will be critical to the continued success of managing the pandemic in the state. And this additional information would be very valuable in meeting some of those ends as well as other public health priorities. So thank you very much for everyone attending.
Thank you. So Mike, to your point, what we would propose, if this sounds reasonable to the work group, is that we have two parallel tracks. There could be some members of the work group that view themselves as more of a technology expert and would be much more valuable to the process by working with CRISP to work through what we might call test challenges that are different today than they were back 5 years ago when the transaction pilot was tested with Relay. And then there, as Mike, as you've noted, some policy questions that we really need to discuss and work through. So perhaps there's a smaller group on this call that would be interested in supporting more of the policy discussion. And then, of course, both tracks coming back together intermittently, and then the sharing across these two different subgroups, if you will. So before anyone commits to that process, and perhaps, Mike, it's change that really sort of spearheads both, if you will, for the moment, being the testing of the 37P in somewhat of a voluntary approach to work out the technical challenges or identify them and essentially to make recommendations on resolving. And then there's the policy arm. And that's what I propose we consider. And before I dig into the issues of policy, does this seem like a reasonable approach to everyone? Okay, hearing no objections, I will assume that that seems like a reasonable strategy. Mike, is there an interest among do you think there would be an interest, and it's worth checking on with your team, that you all might be willing to work with data in a test environment with Chris to help them identify some of the technical challenges?
Yeah, David, I think we're all in agreement that we want to make sure that the citizens of Maryland have the data they need to, receive the best care they can.
Sure.
I guess there's just a lot of operational questions and technology, expense, I'll say, and that we probably have to understand completely so that we can, do what we need to do to, to help fulfill that need, but do so in a manner that's going to inform your state designated HIE in a manner that is beneficial to the patient care and treatment in the state of Maryland.
And I agree. I think that makes sense. What I would encourage us to do, at least for the time being, is separate the financial model of it, because as you probably note, that the legislature had included in the law very specific requirements around who cannot be charged for providing these transactions to CRISP. So there's not a lot we can offer in the way of that funding, of a funding model there. But I think what we can do is just sort of carve that out for the moment and and look at the other policy challenges and be very mindful of the impact of any policy decisions on the element that you noted around the financial implications. Because if we give this some thought and really stretch our boundaries of thinking, we may come up with ideas that allow for least very what we might call minimal impact to the financial component. So while that's not the perfect answer, I think we might be better served if we just start with the big policy questions and then see where that leads us, because I think that gives everyone a good handle on what it means as we go down the pathway. And so much, we greatly appreciate your willingness to support the General Assembly's legislation here. And so thank you for acknowledging that. And then what we can do is, if you think the group thinks that we want to, on the technology issues, if we, rather than actually move to testing, if we move to identifying what they are, perhaps that gives CRISP a way to step back and think about what they might need to do to help make recommendations to resolve that. So it's less of a physical exchange of data and more of a discussion around what does that sharing or pushing look like. Mike, does that get to some of the points that you were raising?
Well, I think we're talking about them now, yes. But there are also, since the initial pilot, many years ago, in the 2019 study that came out of that advisory group that the Maryland Healthcare Commission reported back to the governor, which by the way was pointing out some of these same things in 2019 that are now being brought up in 2021. I guess there have also been federal regulations that have been enacted and are now effective around the the CMS interoperability and patient access final rule, where in that final rule it designates a HL7 FHIR patient access API as a means to allow the patient or the actor that's acting on behalf of that patient to receive administrative data. But that is an entirely different workflow. EHNs are not directly involved in that patient access API or the Blue Button API. So there are several things that have, taken place between, 5 years ago, 2 years ago, and today.
Sure.
that I think should be looked at.
Absolutely. Well, I think you've identified some great work that kind of is an offshoot, if you will, but it's absolutely great work. So we have a lot of team, the MHCC team here, as somewhat as note takers. Why don't we see if we can identify, and Amy, can you just begin to type in, either open up a fresh sheet or add in here, let's talk first a little bit about policy. And why don't we add an item, why don't we go all the way to the bottom where it says next steps and just enter in a new page and just put policy items for consideration. And let's begin to talk a little bit, just we can identify them and we'll put them on the list, and it gives us a place for all of us to start from. And we'll set aside the technology piece for the moment. And we also want to, as I suggested, rather than starting with the funding component, let's set that aside. We hear you. And let's start with some of the specifically related policy challenges. And yes, there's been a lot of really great work on the federal level. And some of you all have been actively involved in that, and that's terrific. But again, if it's not a direct impact on the networks providing data, on this case, on the 837P to CRISP, let's just put that in a parking lot for the time being, and perhaps we can come back to it. But to keep our list focused for the time we have today, let's just talk a little bit about what might be the policy areas that we need to explore. We obviously won't have answers for them today, but if we create a running list, it gives all of us some homework. Mike, do you want to start off and see if there are a few that you might think we should put on the list here?
You know, it's interesting that you're asking us when you're the policymaker. So I guess, has MHCC done any legwork to understand what some of the policy considerations may be?
Well, I think there are some policy challenges. It's there, and I'll just name a few. But again, it's really not. I mean, we would definitely add ours to the list as well. So I'm happy, and the team here is happy to start. Some of that is policies around education. So there's a provider education component. There's a consumer education component. There's a question about potential, and we'll just call it a potential opt-in or opt-out, or rather opt back in. You know, is that a component? Again, these are just broad ideas. We may end up drawing a line through it. There is a component around on the 837P as it relates to the mapping of the address, because perhaps it relates, and this may be a bit on the technical side, but I think it has a foot in both camps. On the practice management system or the billing system, is there an easy way to do this? Whereas if the HIE were identified as a payer within a practice management system, it would be a simple routing. I say simple, I don't mean to simplify it that much, but it could be just, it could facilitate a routing process and less work on the HIE, on the EHNs. I think we also have concerns we want to explore a little bit around the privacy and security of the information, both in transit as well as at rest, that we want to look at. We also want to consider potential use cases that are public health related, but also those use cases that may be valuable to the networks, where they could see the information that's collected in aggregate could help them in some of the work that they're doing within their organization in Maryland. We also want to explore how this data might potentially be available for researchers. Is this something that we see that researchers who have specific needs and through an improved IRB process are able to access the information? I think we also want to consider the complexities of implementing a policy approach that results in technology, a shift in technology, on the impact on the networks. So I think a policy question is that we want to try to resolve is what approach to data sharing can have the least impact to the electronic health networks, because as you noted, Mike, and we've tried to sort of set this aside, we're not at all turning a blind eye to your concern about the financial implication. But I think, as our executive director pointed out, the legislature and the governor have enacted the law, and we want to move forward in the way that we best can that minimizes the impact to the electronic health networks, but also everyone else involved, because there may be a provider element, as we have listed on the policy items, that we want to talk through. So these are items that come to mind readily, and admittedly, while we've thought a fair bit about it, I'm by and large just sort of having a brain dump here and looking at the list, and we'll clean up the list because, as we noted, we're recording the events recorded. We'll go back through and clean this up a little bit. Looking at the list, are there some obvious edits that you all might want to make? Or now that I've thrown a few of the items out there for consideration, would you go, oh yeah, I think we need to add something else here?
Hi, this is Kathy with Ability.
Hey, Kathy, please proceed.
I'd like to know just the data requirements that you're talking about. Are we talking about, the patients in Maryland, the providers in Maryland? Are we talking about COVID-related diagnoses? Are we talking about all claims? I mean, can you kind of go into the requirements that you're seeking?
Sure.
That you have.
That's a great point. And Amy, why don't we just put that on a list of policy items so we can help? But just to sort of frame the discussion, and we started out early on by saying we're talking about a really go slow approach. We're looking at graduating into the transaction standards we initially had conceived of, but I don't think anyone has rested their laurels on this approach completely. But if we were to take the 837P, and because it's the law here in Maryland, it's for providers that are in Maryland that are treating Maryland residents. So we're not looking at national data. And by the way, even this approach we may need to talk about, because you might say, well, there's a better way to try to get to what we're getting at, because as our executive director noted, it's for public health purposes in the state. By and large, and so we really need information on what's happening with Marylanders. But that's an interesting policy question, and maybe you all have some ideas there as well. So it's not the information I'm sharing isn't a specific to saying this is the answer. It's sort of a guiding in the direction, which as we start digging into the policy discussion a bit, we may end up shaping it somewhat. How does our list look so far? Are there other items you all might say, oh, let's just throw this on here for takeaways to dig into a bit more deeply?
David, this is Mike Dennison. Because the meeting was on Google Meet, I am not able to see your list.
My apologies. And we can work with the group here. Maybe there's a better way to conduct the meetings that is more convenient or conducive to you all at the next meeting. And Mike, we will, let me just sort of read the list, and please note this is a rough list, and Anani was doing a really good job just trying to type as we were talking. So we've pointed out policies around education, that's both providers and consumers. We added on here the opt-in, opt-out discussion. We've also added here around the impact of the 837P via mapping Again, this is both a technology policy and question as well as just an operating policy around practice management solutions in terms of treating the HIE as a payer. We've also talked a little bit about privacy concerns. That's data in motion, data at rest, and data security. We've talked about the sharing process back to the networks for potential use cases that you all might find of interest, where you could have access to the data once appropriately protected and through an IRB process, but there would be opportunities to have access to the data. And then the last item we've added so far was really at Kathy's request, which was, can we talk a little bit about the data requirements? Is the 837P too broad to start with? Or should we narrow it down a little bit? And we can talk a little bit about that. Maybe there's provider types that we might want to look at initially versus all provider types. So, and Amy, why don't we put that in parens just to keep that on the radar screen? Mike, does that give you a little bit to think about?
Yeah, that's helpful. Just one other thing that comes to mind. I'm aware that Maryland has an all-payer claims database.
Yes.
Is that not working as you expect it to?
So this I would invite our executive director. We actually talked a little bit about this on Friday, and we're excited actually. So thank you for teeing that up. I think we could invite Mr. Stephan, our executive director, back to the conversation. He's available.
Sure. Thanks for that question. So interesting that you asked that question. The all-payer claims database is working as expected. However, there are some scope issues as it relates to recent Supreme Court actions that limit the ability of all payer claim databases to obtain information from self-insured employers. That had been a question until 2015 and 2016 when in March of 2016 in a case brought by Liberty Mutual, the Supreme Court decided that self-insured employers could not be compelled to submit to state all-payer claim databases. So there is a gap in the data that is collected through this mechanism. We don't see that issue being resolved really quickly. Previously, we had been able to get a significant share of self-insured information, but after the Supreme Court decision, the TPAs, some reluctantly concluded they had no umbrella covering their submission of that segment of data to the APCDs. So keep in mind that the APCD data systems include Medicare, Medicaid, and the privately insured. The flows from Medicare and Medicaid, of course, continue, but it's the private market that's limited. But I think it's also important to keep in mind, Mike, that while the APCD has some important public health applications, the public health applications that we're considering through this legislation are broader than uses that the APCD might come into play for. In particular, information that might flow directly through CRISP to public health organizations as well as the provider community. So it is a component, important piece of our thinking on further in covering the entire universe of individuals subject to APCD reporting, but it's not the only application.
Was that helpful, Mike?
Yes, very, very helpful. Thank you.
Wonderful. So let me ask our friends from the HIE, now that they've seen this list, are there policy questions that come to your mind? And I think we have Brandon, Mike, Craig. I believe that's the group from the HIE. Are there items that you might add to the list?
Well, I think it's a really helpful list. I think it's a really great starting point. One thing I would add, actually, you mentioned this early on, David, is that kind of the whole point of CRISP is to be more or less kind of a bi-directional, for lack of a better term, public health utility in this context. And the electronic health networks are a very large constituent group that has not yet, I think, benefited from the state's infrastructure. And so I think whether it's this specific list or something that we put in a parking lot for another call, I do think we should explore kind of if and how HIE data could be appropriately shared back to EHNs for their specific use cases. There's obviously some policy considerations there, but I think it's an important discussion, important part of the discussion.
That's a good point. So we're adding bidirectional connectivity, and I think we've talked a little bit about this in terms of data sharing process, and we'll expand on that bullet point above to note the bidirectional element. Mike, you've had a lot of experience working with this kind of data in the past. Any thoughts that come to mind? This is Mike Fiera.
Sure. I think that the 837 in particular is basically a full-blown encounter, and I think that CRISP is well designed to pull that data and use it just like other data, basically parsing out the data elements. I think from a technical perspective, this is possibly less challenging than some folks are thinking about. So I think it would be really, really helpful to have that test partner to get some test transactions, let us pull them in, see what we can do with them, and conceptually down the road, do talk about sharing data back, perhaps as an attachment on 275 or some other mechanism. But I think it's a very good place to start.
Great. So, Anani, can you just write test partner on the list, and we'll keep coming back to this. Thank you, Mike.
Sure.
Brandon, your thoughts?
Similar to Mike and Craig's, I'm excited to work with a test partner, get some of the requirements back together. I think we can resurrect a lot of the work we did in the past, David, and revalidate some of those things, along with some of the core components around provider directory, where pilot overviews that we submitted to the state in the past, where we had some concerns. I think there's a lot of data elements there, and I think along with Craig, what are the requirements around, what are the policy issues, ensuring privacy and security requirements are there. From a CRISP perspective, I think we have a lot to share around how we've progressed over the last couple of years as well. So those are my thoughts, David.
Okay, thank you, Brandon. From the network side of the equation, I think we have Murray Johnson from Experian. I wanted to give you a chance to weigh in if you're still on the call. Okay, and then let's go to the representative from Optum, if you are still there. Okay, you all may be on mute. Just keep that in mind. So we've got a nice list started. What I would suggest, I don't think we're ready to say this is the list, but I think it's a good start. And Annie, can you scroll up a little bit so we can, for those who are able to see, can see it. What we'll do, our takeaway or homework will be to clean up the list a little bit, and we want to send it out to everyone on the call as a starting point. And if we could get you to add other items, that would help us sequence the conversation in our next meeting. And that would be an approach that I would propose to take. Does that seem reasonable to everyone?
Yeah, David, this is Mike Dennison again. I think that having a list or having something to work from is absolutely going to be helpful.
Wonderful. So before we're probably going to be able to give you all back some of your time today. But before we do, I was wondering if there are any sub-elements. Sometimes it's helpful if we just step through the list one more time. And if you go, oh, within this broad category, here are some of the subcomponents we want to make sure we talk specifically about. And since we've all kind of evolved to the list here during this call, let's just check to see if there's anything we can add to as sub-items. It shouldn't take us too much longer. And so let's go back to policies around education for both providers and consumers. Are there specific items here that might come to mind? And I'll throw one out. It's for consumers, it may be the process of notifying consumers. How do we make consumers aware of this? And on the provider side, it could be awareness building and engagement. Is there anything else in this bucket, if you will, that we want to drill down a bit further into?
David, I'll just add some commentary. Typically, an EHN does not have a direct or contractual relationship with the consumer. If there is, it's typically not directly with the exchange itself. It's more of a consumer-facing type of relationship. And same thing with providers. We obviously have relationships directly with providers, and oftentimes the relationship is through the provider's vendor or technology provider.
So should we add a category here that says payers when we talk about policies around education and awareness?
Yeah, I guess I think I think it sounds like obviously there's going to be a need to provide education, and really I think it revolves around the legality of the opt-in, opt-out, and what we can share without a privacy breach, and making sure we're minimizing or eliminating our risk of a HIPAA privacy breach.
Okay, so and Amy, why don't we add that under opt-in, opt-out policies? I think that's what can be shared. I think payer, education, and I think Mike was talking about what can be shared.
And we also have to think about there are obviously federal policy considerations that need to be checked off, but there are also state statute that is in place today that I believe needs to also be considered.
So let's, and Amy, add that as a policy, but not under opt-in, opt-out, just as tier one. And then, Mike, can you add some clarity on that for us?
Well, obviously, I think there is Maryland regulation around, privacy and security of protected health information. There are policies around disclosure to consumers, patients, residents of Maryland. And there may be others. I think that, obviously, as we're drafting policy, it can't be in conflict with existing statute.
Okay, so we'll dig into that. That's a good point to put on the list. Thank you. Okay. Anything else related to Amy? Can you scroll back up just a little bit for folks? Anything else related to education and awareness for the policies we ought to be thinking about?
Dave, this is Mike. If I could jump in real quickly, would it be worth exploring all the permissions and disclosures that patients sign at office visits today? I mean, we're talking about privacy and what we can and can't share, but when I go to the doctor, I sign multiple things that say they can share data with a CRISP, they can submit the claims for payment and processing and things like that. So as we look at creating new policy, I think it's worth looking at what exists today. As Mike said, the patients have no direct relation with the clearinghouses. So what exists today that may enable us to do this all comfortably?
Yeah, so it's somewhat TPO based kind of question, I think you're saying.
Yeah.
Good point. So I think Murray Johnson, were you able to join? Just trying, you may be having some challenges connecting. Okay.
Yeah, this is Murray. Yes, I finally was able to dial in by a different method. I didn't have anything to add. I just was trying to respond.
Wonderful. Thank you for joining us. So terrific. So let's scroll down a little bit and see if there are sub items under the opt-in and opt-out process. So when you think of the approach we've taken by and large, HIE participation in I believe every state now is always an opt-out, and should and I think the first question is, it gets back to a little bit what Mike Fierro was saying. Should there be an opt-out for consumers from this sort of data sharing? And maybe that's not one we try to resolve today. We just put it on the list because it may be that, as Mike noted, all the documents that patients sign in the provider's office broadly under TPO is that framework for sharing data. So, Anani, if you could just add that to the list, that would be great. Okay. Are there any other items related to opt-out that we should talk about? Okay. Let's look down at the 837P challenges and around practice management systems. This may be a bit technical, but I think it has a foot in both camps for the moment. Is a practical consideration to look at creating, in this case, the HIE as a payer on the communication network of an electronic health network? Is that an element for consideration? And I say that because does mapping enable, and we'll just call it a post office box, if you will, save some of the challenges when a physician may be saying, look, I want to send claims that I'm sending, these claims go to Care First of Maryland. Has anyone thought about the utility of using as a routing stop and setting up an HIE as a network, as a payer? And I think Jeff, this might be a question for you, Jeff Logan.
Hey, David. I'd like to refer to Kathy if I could. This is a little bit out of my expertise.
Yeah, and it's just a broad question. We're not holding anyone to the answers. It just helps stimulate the thought process and gives us ideas for what to consider.
Sure.
Yeah,
Oh, go ahead, Kathy.
but it's just going to take some thought because obviously the primary payer would be Care First in this instance. So, we'd have to think through that.
Okay. Anyone else have any initial thoughts here? Murray, anything from your perspective?
Not at this time, but thank you, Dave.
Okay, very good.
I'm sorry, one thing real quick on if we were to ask CRISP as a payer, even as a secondary insurer, we want to make sure from a policy perspective, we don't trip on any subrogation issues with automated processes that payers that would kick on and investigate secondary insurance as CRISP and things like that.
Okay, so Anani, if you could add that. It's a very good point. Okay, let's talk a little bit about the privacy of the data, how it could be secured. Again, this has a foot in both camps on technology and policy. Is there anything specific here as a sub bullet we want to add to the list? Jeff, I think you may be trying to weigh in.
I wasn't. Sorry, I had my microphone on.
Okay. Okay, so I think data security is just it's a big issue. I think it's an issue for everyone. So let's just add data security here.
David, does it make sense to talk about certifications of infrastructure as just a sub bullet here?
That's a good point. Good idea. Okay, moving on to the data sharing process. Today, Craig, can you talk briefly about how requesters obtain data from CRISP?
Sure, yeah. So maybe very briefly, and obviously we can provide documentation and go deeper on this topic. CRISP data is used as described in our participation agreement and with specific permitted purposes. Research is one of those permitted purposes. And in order for data to be available for research, the request first has to comply with an existing use case that has been approved by our clinical committee and research subcommittee. For example, opt-in, essentially consented research for identifiable data is one of the few research use cases today. And in order for a researcher to access that data, they have to put in the request. We confirm it with any of the data owners if, for example, HSCRC data is requested through CRISP. And then they have to have IRB approval prior to any data being released for any purposes. And then there's certainly time periods, data destruction policies, and things like that when the study ends. So needless to say, there are very clear and precise processes for only exactly the right data to be released to the researchers.
So why don't we add data access, and then we'll just put research purposes, and that's an area that we can talk a bit more about, as Craig noted. Okay, we're almost to the bottom of the list, 2 more items. Let's talk a little bit about data requirements and provider transaction types. So we initially have kicked around the 837P as that first place to start in terms of ferreting out, I think as Mike Dennison noted, the policies around supporting it, but also thinking about what that might mean for testing. And I think that will lead us to our last point. But before we get there, let's put the 837P and put policies around testing. Any other thoughts, Mike? I'll turn to you from Change to see if you had thoughts here.
Well, I'll point out maybe an operational consideration.
Okay.
Obviously, as clearinghouses, we oftentimes work together or work with a vendor, and oftentimes they, maybe originated, the designated record set may be the provider, and they may actually transmit that to, through their vendor software to a clearinghouse. I'll call it clearinghouse A. Clearinghouse A then accepts that claim, passes it to clearinghouse B, and they may reject that claim. So if we're both sending data, you may have claim data that was never accepted or received by the destination payer that may influence your data pool in a way that could adversely affect patient treatment if used for that purpose.
Yeah, so it's a very good point. Why don't we talk about where in the submission process the data originates? Because I think, Mike, to your point, there are also, and I'll just say there are multiple hops, we'll just call it that, from the time provider hits send on a claims batch. And this can be based on the contractual relationships that payers have with networks. So I think what you're saying is we really want to focus in, and this is a good, excellent kind of discussion we have to think about, both from the technology standpoint and just the general policy. Do we want to find a way to call out in that routing process the network that's which is the front door network, I'll call it that, to the payer. So we're not getting 837s that may originate from a practice management system that may come through, that may have multiple networks in the middle. I think that's the point I hear you making. And how do we create this? How do we do this in an orderly fashion?
Yeah, I'll expand on that point too. It could be, even if we were to identify through effort who owns the actual end hop between the clearinghouse and the payer. There's also the complication that even if that claim was accepted in multiple hops, it could be that the payer then rejects or denies that claim, and it's no longer the an authoritative record because the payer actually did not accept that claim or denied that claim. How do we then, as the EHNs, we would not be necessarily informed in all cases that payer had made that decision.
So I think the answer, and we'll add this to the list. So I believe what we're not necessarily trying to get at is paid claims or process. It's not the process of denial or partial payment or rejection that will be the public health utility. It's the service that would be the public health utility. So by submitting the 837P, it would, for the moment, serve as the trigger of a service. It may not be paid fully, partially. It can be the adjudication piece. There's so many elements of that. I think we have to talk about trying to not focus in on a bidirectional exchange, meaning if the payer sends back the response, is that response then needed to be reported to as a transaction to the HIE? And I think for the moment, we might want to focus just on services as triggers as opposed to anything else. And we can have more discussion around that. But I think as we started out by saying, we want to try to at least go slow and keep this as a simple process as best we can. That might be a better way to go. Mike, what are your thoughts there?
Well, I think we can't just dismiss that the payer has taken an action that, does not make it I'll say a clean claim.
That's true.
Where if the payer is rejecting, it could be that, the provider then corrects and resubmits, and that may be they're correcting actual diagnosis or procedure that they may have inadvertently coded in the initial send. But syntactically, it's all okay. So, we as clearinghouses then pass it on to the destination payer, who may use a reference data that we don't have access to make some of those pre-adjudication or post-adjudication decisions.
Yeah, so I think we want to add to this resolving duplicates but I think it stems from, as you noted, from the service. So if the provider sends an 837P and it acts as a triggering event of the service, and then a month later turns around and sends that same date of service again because the payer asked for additional information or they rejected it, how would the HIE resolve duplicates? Because I would think the question here is not for the network to try to focus it, merely to hand it off. And then the HIE would look at dates of services and or other components of the claim to try to mitigate any sorts of, as you've noted, back and forth on the claim. Okay. So
yeah, I guess one of the point I'm making is that in no case will the clearinghouse ever be the designated record set holder and hold the sort of information or knowledge that is in fact a service that was actually rendered. It is properly codified and includes all the information possible. make
Yeah.
any claim transaction.
That's an excellent point, and I actually don't believe that that's what we would expect or would be aiming for, because I think, as you noted, the complexities of that could be endless. So it's about 9 minutes before the hour. What I would propose is we just sort of wrap up here. We talked a little bit about next steps. From our perspective, I want to thank everyone for joining the call today. It is our hope that we can continue to keep you engaged in this process, and we'll try to do as much of it as we can virtually, or rather electronically, so we can build these lists and we can share information before we come to a virtual meeting. And we really make good use of your time when we have these virtual sessions. So our takeaway is we're going to clean up the list of policies items that was discussed. We want to share it back to you all in a draft to see if there are changes that you wish to propose to the list or add other items to it. We would then we'll work through these items and then identify a next meeting date. We believe we're trying to aim for about 4-week increments. Melanie, is that correct?
Yes, that's what we had. That's what we had said, about every 4 weeks. Yeah.
Okay. And hopefully we can keep you all engaged, and we'll look at if there are different platforms for the virtual meeting. That's your preference. If you all can just share that with us, there may be a different platform we can use that would accommodate the viewing process from everyone here, or for the most part. Let me turn back to Melanie for a moment. Are there remarks, Melanie, that you need to make here?
No, just, again, I want to also thank people for their time. This has been great information. We will post, in addition to what David said, that list of policy items, we also post a high-level meeting summary and the video recording for this meeting online. And any information about forthcoming meetings will be sent to you. You should receive a calendar invite. You'll receive an email, but they'll also be posted to the MHCC main page in the meeting section.
Okay, and I thought I'd turn back to our executive director to see if he has any comments that he'd like to share.
No, I want to, again, thank everyone. I want to also thank David for nimbly putting together a dynamic list of issues. I think we want to look at that list to make sure that we're not we're keeping issues in their policy or technical domain. I do have some questions that we'll work through with staff about that. But I think with your support, we did get a pretty comprehensive list of the policy questions that need to be wrestled with as we move forward. I think a key point is that we've really only talked about one transaction today, but as the domain of public health is expanding even as we speak, and there's broad awareness that addressing social determinants of health are roles of the public health community. I think we need to think more broadly about information that is passed through on the administrative transaction set that may address some of those issues. But we'll take them one at a time. And again, thank you for giving us an hour and a half of your time this morning.
Thank you. Is there any comment from any members of this group that you wish to share at this point? Okay, with that, we hope you have a great week, and I just echo what everyone else has said. Thank you very much for your time, and we look forward to working with you as we move forward. Have a great day, everyone, and look forward to talking soon. See you.
Bye.